Hi again. Okay, this video is on ultraviolet radiation. It's going to be pretty quick and simple. It's something that you're not going to see a whole lot of, but you may get one question on your boards, and so just so you know, a little bit familiar with it. Okay, but you're probably, as in the physical therapy world, not going to utilize this anymore. This is usually, like we were saying, in the dermatological office that you'll see this. So again, here's that spectrum that we talked about, the electromagnetic spectrum. So remember you have the electric field and magnetic field, and they blend together, and then you have the gamma rays, X-rays, ultraviolet rays are right in here, infrared rays. So just to confuse us, they flip-flop this, so now they have the short waves over here on our one that we were using before. They had it on the other side. So anyways, your visible light is here. Here's your infrared rays, and your ultraviolet's on the opposite side. Okay? So you kind of just know where it's at. This is what the machines look like. This is more current day. This were the type in the days when I actually had to get skill checked on this when I was here as a PTA back in the 1980s. Just to date myself, yes, but this is more what you'll see now. Here's a different type. So we have the deepest type is the UVA. And these are wavelengths are measured in nanometers, remember. And then here's your UVB, and that's where you get that erythema, redness of the skin, correct? So kind of our sunburn that we might think about in our day. And then the UVC, which is more of a germicide, which it also can be used to help with bacterial growth and killing of things. Okay, so this is just kind of showing you those different wavelengths again. And where they're at. So we can see that the UVA goes the deepest, which is these wider ones right here, and then it gets a little bit more shallow to the very superficial ones over here. Okay. So this is what one of the ultraviolet lights might look like, and it's kind of just talking about the distance between and the angle of incidence. And so that little angle from here to here is how it determines how much is going to go in there. So it's affected by that wavelength, the intensity and power, that distance. So obviously the farther away versus the closer, and the angle of incidence is smaller versus a larger angle, the size of the area. The thickness of your skin and also the pigmentation of your skin is going to affect that, and then the duration of the skin. So here's some of the effects of ultraviolet, that erythema production. We can see that redness in there. We obviously get tanning if we don't over affect the layers there. You get some hyperplasia, which is just basically that kind of swelling of that superficial epidermis. You do get some vitamin D synthesis, and so that's why now when they're saying that people are lacking vitamin D, a lot of times they're feeling that maybe it's being blocked by sunscreens, and so that they ask for you to go out in the sun for about 10 minutes a day to get your dose of vitamin D. And it also has those bactericidal effects that we talked about to kill germs. So you primarily used in psoriasis. They will use it for wound healing a little bit, but like I said, the wound vaccine and the ultrasound mist seems to have replaced most of these other types of modalities in the wound healing arena. So again, contraindications, because you're talking about this electromagnetic spectrum, you don't want them to get close to the eyes. Skin cancers, pulmonary tuberculosis, cardiac, kidney, or liver disease, systematic lupus erythematosus, which is in the autoimmune arena, and if they have a fever. Precautions, we talked about this with the lasers and light, that photosensitizing medications, and certain dietary supplements that make you more sensitive so you can burn quicker. I know when you're on certain antibiotics, you're supposed to stay out of the sun because they're photosensitizing, so it's the same kind of thing. So you just want to know what kind of medications your patients were on before you used it. Recent X-ray therapy, so we talked about the radiation therapy. The tissue is very fragile, and so you want to let that heal and the skin to get thicker before you put any kind of heat on that. So you never want to repeat a dose of ultraviolet radiation until you've seen the effects of the previous dose have disappeared. So let's say you've treated somebody and they have some erythema in there. You're not going to use that ultraviolet again until that erythema goes away. Adverse effects, burning's always that thing, that premature aging of skin. So we know those of us who were skin worshipers in our youth are finding that out now. Obviously, you can get carcinogenesis, which is cancer, skin cancers, eye damage. Swirling with the UVA, you can get nausea and vomiting 1 to 4 hours if taken orally, and you can get skin damage. Okay. Application techniques. So this is something that if we were in class, we could practice this. If we have extra time, I can just show you how this works. You first determine the patient's sensitivity using what we call a dosimetry procedure. And this is kind of where you might get this on the boards. And this is called the MED. And you can look in your camera book just to kind of refer back to all of this. You're going to use the same lamp every time for assessing the sensitivity. Resif if you have to use a different lamp, or there's a long time between treatment sessions because some things could have changed with your patient. And of course, you're going to always check the skin pre and post, their sensation, any open wounds, any areas of excessive redness or burns, you're going to want to not use it on. So your minimal erythemal response, and we call it its dose actually. So MED is minimal erythemal dose. You have a long piece of paper and you have these squares and you expose each area a certain amount of time. So the first one that you're doing, this is like a test strip, kind of if you've ever done photography, you're going to do the same thing. So you're going to do one at 30 seconds. Then you're going to move that, and so then the second one's going to have that 30 seconds plus another 30 seconds. So it's going to be exposed for a total of 60. Then this one's going to be a total of 120, and this final one is 240 seconds. And so then you're going to see the response to that so you know the appropriate dose. So if there's no change in redness, occurs in the 24 hours after ultraviolet exposure. So that's what we call the suberythemal dose. The minimal erythemal dose is where we want a little bit of redness because we want to get some vasodilation going on in there. So that produces it within 8 hours after exposure and disappears within 24 hours after exposure. So this is where you really have to rely on your patient to say, oh yeah, I got some redness there, a couple hours afterwards or 8 hours afterwards, but then by the time I came to see you again, it's gone. So then that's a good dose for you, and that's where you would start your patient. So you can see there's a little bit of a objective problem going on there with that. If they're in an inpatient setting, you were doing it, then I guess that would work. First degree erythema, that's at E1. So that's that definite redness with some mild desquamination. Appears within 6 hours after exposure and lasts for 1 to 3 days. So that's that mild sunburn that we get when we forget to put sunscreen on. This is generally about 2.5 times the minimal erythema dose. And it just goes on. Second degree, that's when you start to get the edema, the peeling, or that hyperplasia that we talked about, 2 hours or less after treatment. So that's that more severe sunburn. And that's about 5 times your minimal. And then we go on to that third degree burn where you have the blistering, the peeling, you get oozing, that's that exudation, usually about 10 times the MED. And then there's just kind of that warning that this Serolin is that photosensitive medication that people who have psoriasis might take. And so it's going to, you want to make sure that you test this about 2 hours after they take that pill, or if they're putting the topical on. Okay. So here's a sample treatment. You're going to have those goggles on the patient and yourself, same like we did with laser and light. You're going to take away any clothing of that area to expose it, jewelry, so you're not burning it. You're going to wash the area that's least exposed to natural sunlight. So you want the most susceptible area because you're going to want that minimal erythema dose. So that's how you test it. So there's that cardboard or piece of paper with the squares. It's just a test strip. You place the lamp and you're going to measure that exactly. You're going to say whether it's 60 or 80, so it's replicable and it's perpendicular to the area. And then you're going to cover all but the one hole like we talked about, and then you slowly turn the lamp on and you just uncover each one as you go until you get done with it, and then they assess it to get that MED. Here's just a sample of the documentation. Again, when we talk about skin checks pre and post, to say, are they intact? Is it red? What were the results? Are they taking any kind of sun sensitivity medications, the body part that was treated, the type of UV radiation used, the serial number of the lamp so you can replicate with the same one, the distance of the lamp, how long you did it for, and how did they respond to it. Okay. And that's that for ultraviolet radiation. Thanks. Bye.